Well, well. Should the door stay open?
New setting. No, we're gonna close it.
By the way, this is the first time we use
I
this.
heard.
Yeah.
I heard.
So,
Exciting.
Mo didn't want to announce it. He just wanted to kind of happen.
Of course.
I was like excited. I was like, tell everybody. He's like, Z, pretend you're cool for a second. Just let it flow. So, yeah. So, first of all, much props to the team. Mo, of course, and Diana, who was on the live.
Yeah.
We interviewed her. She was awesome. She's the designer for all things Baker Health, like our offices, our yoga studios, my house, and this concept. So we would do this in my office upstairs, or sometimes in the clinical office.
Yeah.
And she was like, "It's really a shame." I'm like, "What's a shame?" She's like, "You have really smart people that take time out of the day to come talk to you, and you do it in such a sloppy setting." I'm like, "What?" She's like, "You should have a setting that matches the conversation." And as always, when smart people start to talk, I'm confused, but I'm smart enough to let them finish. And by the end, it kind of makes sense. And the smartest thing a dumb person like me can do is just listen and follow their lead, and voila, she produced this. So this is probably the most unique topic we've covered.
For sure.
In maybe 6 months of doing this. It is it's an interesting, funny, some might say sad, I would say important topic, and it's unique in the following manner. Um, we've covered cardiology and heart disease and hypertension, and that's a common topic that's covered in healthcare, and rightfully so, right? Millions and millions of people have heart disease. We've talked about diabetes, we've talked about mental health, and those things are super important. But not everybody suffers from mental disease. Not everybody suffers from hypertension. Not everybody suffers from obesity. The one thing everybody will experience is death. And even saying those words, I feel like, did I just say something bad? There's such a stigma that
That's so true.
even me saying, "Hey, we're all gonna die," like just saying that, it's like, keep it down, whisper. Why? We're all gonna die. And as doctors, I think even doctors have a weird relationship with death, as if it's a failure on our part.
That's so true.
It,
That is
it's
so
it's an inevitability. Now, I think a failure, and it'll bring us to hopefully a really nice conversation tonight, is in how or when we let our patients experience death, the manner, the timing, and that maybe you could hang some of that blame or credit on us, right? Do they die with dignity? Do they die with the right support? Because there could be victory in death,
Yeah,
right?
absolutely.
And so I think it's a unique topic. I'll tell you, this is the topic I'm most excited to learn about. Not only as a doctor, but as a pediatrician, I'm happy to say I'm a little far from it, right? Like, of course, I've lost my fair number of patients, but my brother's an internist, and he deals with it a lot more than I do, and so I'm looking forward to learning about it. We have a really renowned expert. I'm going to let her kind of talk about her journey. We have mutual friends within healthcare, and it's an honor to have you here tonight. If you don't
Thank
mind,
you.
just introducing yourself, your personal journey, your professional journey. We always love to hear how you got to where you are.
Okay, so I came to the U.S. approximately 31 years ago. Was practicing surgeon back home in India. Uh, Came in, started family medicine after a year of surgery. Slept on the George Washington Bridge, and my husband says you need to change. so, so switched to family medicine, but realized very quickly that I needed some more expertise in medicine before I could start a practice on my own. Did geriatrics for 2 years and learned very quickly that I needed to get comfortable with talking about dying and dying with dignity because geriatrics, if there is something that is certain in life is that we are all going to actually eventually pass away. So, and it is, I wanted to make sure that I was as comfortable as, talking about dying, and talking about dying myself and feeling comfortable in my own skin talking about dying. And so I could make it, comfortable for my patients and their families. So that is how did. I finished my geriatric fellowship at Montefiore. Went into hospice and palliative medicine to get more and more comfortable. I've been practicing hospice and palliative medicine since 2003 now, and and eventually, I think the principles of palliative care are really based on geriatrics, and they're kind of interchangeable. But we know that um, I think we need the fields of palliative medicine because it's not just geriatric patients who pass away. And as we all know, that during COVID, we learned a big lesson. Not everybody who was geriatrics was passing away. Yes, majority of patients were geriatrics, but we had a lot of younger patients. In fact, I think the first death in New Jersey was a 27-year-old. So we all, as physicians, as a community, as a support system, as a family member, as a parent, as a child, as a uncle, aunt, we all need to get comfortable with this conversation. So,
Yeah. And can you do me a favor? Could you define some terms for everybody watching?
yeah.
Geriatrics itself is not even very well understood. And then palliative care, like even palliative care, I think we've talked about it in the first few minutes. We've danced around it, but can you just define some of those terms?
Okay, so geriatrics is a field of medicine where we talk about taking care of elderly, generally over 65. Um, and palliative medicine is actually a field of medicine that has evolved over the years, and it is about supportive care that is provided to a patient, their family, by an interdisciplinary team uh, for a patient going through a chronic serious illness. So we're talking about chronic serious illnesses like advanced dementia, Parkinson's, cancer, multiple sclerosis, ALS, advanced COPD, advanced congestive heart failure, so advanced cardiac disease. So we're talking about really chronic serious illnesses that have implications beyond just medical. They affect how the patient's quality of life is. It affects how their family members are. It affects everybody around them. So those are the illnesses that we are talking about when we take care of palliative care. And hospice is a Medicare benefit that a lot of people confuse between palliative care and hospice, but they're not the same. Palliative care is really truly needs based. It's not prognosis based. It's really needs based. People with chronic serious illnesses have financial burdens, transportation issues, understanding their disease, symptom management, whereas hospice is a actual Medicare benefit, and that is for people whose prognosis is less than 6 months.
Right. And you help in both capacities.
I do.
Right. And so palliative care might be somebody who's living with a serious case of lupus. It's
Absolutely.
debilitating. They need to work. They used to
Mhm.
drive, now they can't drive. They used to be able to feed themselves. They can't. My mom passed from diffuse systemic scleroderma, like
Mhm.
severe scleroderma.
Mhm.
So, you see like a vibrant person who's young in her early
Yes,
50s and then just debilitated. And so that's one situation.
Mhm.
And they may or may not have a good prognosis, meaning
That's correct.
they might be living for another 20 years.
Yeah,
But hospice is when the proverbial, doctor comes in and says you have 3 months to live,
that's
right?
correct.
Like end of
Mhm.
life, we've tried everything, and now you're pulling the family in, and
That's
now
correct.
it's kind of how it affects the individual and everybody around them, and then that's where it gets really sticky, right?
That's very true. I mean, hospice has a stigma attached to it. And I think the benefit is that up until now, the insurance companies and the payers were really not recognizing palliative care. But in the last, I would say, 3 to 5 years, there is really a good understanding. And we've had really good studies to prove that the patient's quality of life improves, the outcomes are better, it's more cost effective. It is definitely, there's early adoption of hospice when patients are on palliative care. Their moods are better. The family feels supported. The patients feel supported. So I think there is a lot of uptake of palliative care and support by the payers. So you'll see a lot of change. In fact, um, in my work with one of the other companies where I started the palliative care program, we did partner with a Medicare Advantage plan to provide palliative care, home based palliative care to their members living with chronic serious illnesses. And they saw a significant drop in the utilization, the ER utilization, hospitalizations. They definitely saw an uptick in improved compliance with medication management, improved compliance with physician follow up. So definitely has a big role. And the study that was done by Dr. Tamel at Mass Gen, what showed that the patients who were on palliative care, living with advanced lung cancer, really they lived 4 months longer. There was early adoption of hospice. They never received chemo for the last 2 months, 2 weeks of their life. They were less depressed, and their family felt supported.
Yeah, that's incredible.
It is incredible.
And at the same time, not surprising.
Yes.
You know, what I always tell people when families will come to me, usually not about the kids I'm taking care of, but they trust you that you take care of their kids. So then they have their cousin who's dealing with
Mhm.
something in North Carolina, and they come to you. They ask for advice because they're
Of course.
desperate, and if you have a trusting relationship,
That's
so
so true.
they're like, hey, Z, my sister, blah blah blah, this that, she got whatever, and last two times I saw her, quote, she's not even there. I can't tell if she's in pain, whatever. And these days, I advise them to seek out somebody with your expertise, because it's not a black and white answer. Um,
Absolutely.
in the old days, I used to just, I would even tell my loved ones, I would tell my wife, I'd say if there's any question, pull the plug. That's what I used to tell my wife. And it's crude. But the point I was making is seeing what you see as a doctor
Mm.
and how aggressive we are in healthcare, where we see something, we cut it out, we medicate it, we treat it. We never pause to say, all right, what can we look around this or over this or under this? We're always like
Absolutely.
very interventionist, at least Western medicine. And many times that's good. And many times it's curative, but sometimes it's not good. And sometimes it does more harm than good. And so we
Absolutely.
see that, and every situation is different, but the one thing I know is there's going to come a time 100% where doing more is not the right thing.
That is so true.
And as a healthcare system, our instinct is to always do something. So at some point we're going to have to call balls and strikes.
Absolutely.
And I think that this is what the conversation tonight is about. And Mo, I know we have some questions probably already coming in, but I just want to ask some of my own questions because I'm fascinated by this topic. So the first question I have, who or when pulls you in? Like, so, I have a diagnosis, it's terminal. I'm starting to get in bad shape. Is it my primary taking care of me who reaches out for your expertise? Is it the family has to know that your services exist and they consult you? When are you pulled in?
So, I think there is a lot of more education around this now, and there are families who are seeking it. But yes, I think more education is still needed. A lot of times, I'll tell you, it is the interdisciplinary team that pulls us in. The social worker will see that the family's struggling, or the nurses will see the families are struggling, um, because the primary team will come in, explain the prognosis, explain that there is, no cure at this time, and then the families feel like, oh my God, everybody's given up. And it's not that we've given up. And I think we need to all rephrase it. We can provide care at all times. We might not be able to provide cure at all times.
Exactly.
So I think that is the distinction that we need to make. And, there are significant tools that we have that can, we have prognostication tools, we have screening criteria for palliative care. And, so if they use it, and they are very well researched tools for, especially for hospital based medicine physicians. And now we actually developed a tool with CAPC for our skilled nursing facilities when I was working with us. And then, so there are tools that you can use. And a lot of times it's also about, symptom management. So if there's intractable pain, intractable nausea, intractable, diarrhea, nausea, vomiting, whatever, then um, then the primary care team might pull us in. But since palliative team is an interdisciplinary team, so which is, obviously the physician is the lead, then, so you could have an APN, PA, but it's a lot about the chaplain, it's the social work, and so it is really an interdisciplinary thing. So it's not just about physical pain; it's also psychological, spiritual, existential. We are trying to get to the root cause of any kind of agony that this patient is going through, so that they're passing, or even if they choose to do some kind of chemotherapy or they're choosing to do some kind of treatment, that it will not be that much of anguish around that, between the patient and the family, and then everybody is a little more calmer around the treatments.
Yeah. One one that explanation reminds me one time when somebody who was very close to me
Mhm.
was in the hospital getting a transfusion or something and pretty bad shape and towards the end. I remember I'd go see them, and there was like a room next to them that eventually, you start
Mhm.
to talk to. And I was in training at the time. I was a
Mhm.
resident. And the people next to the person that I was close with, they did something interesting. Um, they had, I forget how they called it, but it was
Mhm.
effectively a pre-funeral, where what they did was they had like a party. I mean, it was a ugly, dungy, sterile,
Mhm.
stinky hospital room with a very debilitated patient, but they had balloons, music, alcohol,
Mhm.
and they were hanging out. And when I asked them what was happening, they said they were, having a party to celebrate this person's life. And clearly this person didn't have
Mhm.
much more life. And that's something that's counterintuitive. And it reminded me then, and listening, I haven't thought about this moment in
Mhm.
years. There's a funny interpretation and a more kind of melancholy one. One of my favorite shows is Curb Your Enthusiasm with Larry
Mhm.
David. And one of his friends has an episode where he pretends he's dead because he wants to hear what his friends will say about him while he's
Exactly.
alive. And
Mhm.
To me, Kirby Enthusiasm is the funniest show ever. Okay, and Larry David, and he's the creator of Seinfeld, right? And so that's the whole episode, and it's hilarious. But then the more melancholy one, I don't know if you ever saw the movie Philadelphia with Tom Hanks. And when he's in he's like this accomplished lawyer, and they're celebrating his siblings, and everybody's celebrating his life, and he's dying of HIV. And it's an interesting thing because on first pass, at least in our culture, um it's almost distasteful.
Mhm.
You're like, someone's sick, stop, turn down the music.
Music, yeah.
Someone's sick, stop laughing. But if you give it a second thought, it's actually, I think, a deep sign of respect and love. Like, all the hoopla after the fact is
Mhm.
for you, not for them.
Yeah, exactly.
And so that's,
Mhm.
to me, a psychosocial extension of what we're talking about. And so a couple of questions I have. One, you touched upon the non-medical aspects to this, like the clergy or the
Mhm.
mental health or the.
Mhm.
Can you talk a little bit about how that happens? And then the second question, you could take them in whatever order is. In some places, in my experience in medicine,
Mhm.
like, how we treat strep throat, that's not very different from here to New Zealand. Some places, how we treat pneumonia,
Mhm.
but some places, Europe or other parts of the world, and Asia, the Far East, it's night and day. This seems to be a place that there's a huge spectrum of how different cultures
Mhm.
treat end of death.
Uh-huh.
And so, can you talk a little bit about the spiritual, mental component, and then talk about cultural differences, whether within the US or if you compare us with other countries that we can learn from how they deal with end of life?
So large variation, of course, and I think the reason that in the U.S. it's so different is because we are so used to having you know Medicare or an insurance pay for all the benefits that we have. So palliative care right now is like a Part B benefit, and hospice has been traditionally a Part A benefit, and that is 100% covered. Hospice is you don't spend anything on hospice except for room and board if you want to be in a skilled nursing facility. Otherwise, the medications, the transportation, everything that you might need for comfort is all covered under hospice. Palliative right now, because the way it is paid for, only the physician component is paid. So, but certain companies have made sure that, and a lot of hospice companies have done that because they already have the team. They have the social worker there, they have the clergy there, they have the chaplain there. Um, they will send their chaplain in if there is a lot of psychosocial distress that you see. If you're seeing like there's a lot of existential distress, they will. So I'll give you an example. I had a patient who had very advanced coronary artery disease. I mean, she could not sit from the bed she could not get out of bed to the chair without having chest pain and angina. And she was dying. But then she had a secret that she wanted to tell her son. And she had not disclosed the secret. And she was a Holocaust survivor. She had run away from the camp. And she had, when she had run away, she had eaten a piece of meat and she was very full when she was caught and brought back to the camp. And then they gave her a piece of bread and she knew that she wasn't hungry, but she still ate that piece of bread, even though she knew that everybody around her was. So she was really going through existential crisis. It was nothing to do with pain from her disease. It was nothing to do with anxiety or depression. And she had not shared this with anyone except for myself when I went to do a palliative care consult for her. And she said that, and this was as I was leaving the room, she wanted to share this. And she said, "Do you mind? Can you wait till my son comes in? And I want to share it with him." I said, "Of course." But then I also realized that I would need the chaplain services at that time. So while we were waiting for her son, I got the rabbi, in to see her. Um, and I think it was a beautiful meeting between the son, her, the rabbi, and then she went home on hospice, and she passed away very peacefully.
Wow.
Because she felt like she didn't want to die with that guilt of having eaten that extra piece of bread when even though she was not hungry. So she felt like she could have shared it with somebody else. So I think it is not always about medical. It's a lot. I mean, obviously you have this chronic serious illness that is making you eventually pass away, but the stress doesn't have to be always related to the disease itself. And you do need an IDT team. I always say that. I mean, and it's sometimes it is the patient themselves, and sometimes it's the family, because obviously our lives are crazy, and the children are in a different part of the world or a different city in the U.S., and they are going through that guilt trip of not being there for their parents. Um, and they keep saying, no, 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 do everything, and do everything, because now they haven't been there.
Yeah.
That they want to hang on to every last minute
Right.
that they think that they can spend with their parents. So, and again, to bring them in and try to sit back and see, what is it that is making you want to do this? Because this is really not working for your mom or your dad. It is kind of futile. It's really affecting their quality of life. It is, affecting the way they are, and it's causing them distress. So I think the team is very important. I really believe the team is very important. The medical physician can go in, obviously symptom management, their pain, their nausea, their diarrhea, their whatever other symptoms that they might have. But I think eliciting really what is it that this person is going through, that is really the underlying issue that is causing them so much distress. And sometimes it's medicine, but a lot of times it's not.
How often are you dealing with a situation where there's like a conflict of interest? So you might have the wife or the
Mhm.
partner or the husband or whatever, and then you have a child or two,
Mhm.
and you have, three different perspectives on do everything you can, just make him, let him die peacefully
Yeah.
versus, and how often do you deal with that, and how do you navigate it?
So I
Also,
think the
can I also add like another
sure.
part of that question? Do you ever have like physicians who like go against what you say and try to give you their own advice,
Oh,
like
absolutely.
as the families?
Absolutely. So I'll tell you, this is a very common scenario. And I think what I tell my patients, being a geriatrician, I tell them when I do their annual reviews, I say that the biggest gift you can give your children is the gift where you have outlined what you would want for yourself. I have seen families split over it. I've seen children not talk to each other for years after their parents' death, uh, and real ugly, scenarios when they are trying to navigate this. It's a very emotional time. It's highly emotional. You are thinking that if you don't do this, your parent is going to die. Who wants to think like that? Even though you might be saying that this is the disease, it's not you that it's doing anything. But at that emotional state, nobody's hearing anything. They're just hearing what they want to hear. So I personally will tell you, if there's one message that I want to convey to the community, is there is a very easy way to really state your wishes. 5 wishes is the name of the document. It is very inexpensive. For my practice, we buy it. We don't even ask our patients to buy it. Um, it's a legal document. You don't need to spend thousands of dollars doing a living will. It really has essentially who your proxies are. It has very common scenarios of what your end of life could look like and what would you want for yourself. It doesn't have to be, we're not translating this into an order at this moment, but it's actually just trying to elicit how you think about yourself. How do you think about your death? You know, we're not saying this is happening now. This could be happening 5 years, 10 years, 15 years, 20 years down the line. I actually had a 5 wishes, which I did when I was going through my fellowship, and I wanted to be comfortable in my own skin talking about this with my patients. So I said, if I don't do it, how am I going to tell my patients to do it? And then I redid it when I got COVID in March of 2020, and my kids were older than 18 at that time. So what I have done with the 5 wishes is I've almost written it like a letter to them. And I've said, you are my healthcare proxy because I want you to honor my wishes, not change my wishes. These are my wishes. This is how I want to be treated. This is what I want to be done when I'm in any of these situations. So I'm hoping that you will honor my wishes. It is not you who's going to kill me. It is going to be the disease and the process. So I don't want you to live with that. So I've actually written it as almost like a letter. Um, and I'm lucky because I have seen all of this. Not every one of my patients is as lucky, but I'm open to discussing this over and over and over again. And I review this 5 issues with them every year on their annual physical, because things change, perspectives changes. They could have had a new disease process. The healthcare proxies that they chose might not be able to make decisions for them any longer, or they could have passed away also. So I think it is the most inexpensive legal way of documenting your wishes. And I think if there
Is
is
this a
one,
website? Like, is this
5 wishes is a website.
5wishes.com kind of thing?
Apps, it's I think 5wishes.org.
.org, okay.
But if you Google 5 wishes, you can easily get that document. But for my patients, I just have it in my
That's great.
office. And I have it in 3 different languages. Obviously, I have English, Spanish,
When should someone start to
18 and older.
right. Younger
Yeah.
than you think.
They're younger than you think.
Yeah.
Yes.
The second you understand this conversation, you should do it.
You should do it.
Right. Right. I mean, right, yeah, yeah. That's awesome. That's incredible insight. I hope everybody takes it away. Because yeah, it's crazy. Like, think about, I mean, you're in a unique situation, but for the average doctor, all we talk about is everything except the elephant in the room.
Mm-hmm.
Right? Like, all the lectures I've been to, all the grand rounds, all the morning reports, all the conferences about developmental disorders, about
Mm-hmm.
increased obesity, about
Mhm.
diabetes, about atherosclerosis. I mean, I've been at thousands and thousands of hours of talks, an hour or two about death, and that's the only thing we're all going
That
to
is
struggle with.
certain.
So yeah, even the old saying was, the only 2 guarantees are death and taxes, but Florida, you could avoid income, and Dubai, you're out of it all. So now it's just death. Should we
Depending on
open it
who
up?
lives.
I could hog this conversation all night, but we should open it up.
Yeah. I have a couple. I have a couple good questions. Um, that came from the chat. Someone, and this one was asked a couple of times about DNR. The first question that we got asked, someone asked, what support and education does the hospice team provide to help families make informed decisions regarding DNR?
So it is.
Should
It's
we define
really
DNR first?
yes.
Yeah.
I think so. DNR is do not resuscitate, essentially, and resuscitation is such a complex issue. Um, it is definitely part of, if you do the 5 wishes, it is definitely explained in that 5 wishes as well. It is the whole process of, what happens to you if your heart stops? How do you maintain their airway? How do you maintain their breathing? How do you maintain their circulation? And what an individual goes through when they're being resuscitated. I don't want to have the gory details on this podcast, but resuscitation was meant to be for the population where, had sudden collapse between 40 and 60, who had a sudden collapse outside, they resuscitated, and then, good. But patients who have such extent of chronic serious illness and their recovery back to baseline or even be able to perform what they were performing before is very minuscule. So I think hospice really does a phenomenal job. It's a whole team. Again, it's not just the physician. There is physician. There is the chaplain, the social worker. They all surround and support and provide education about the resuscitation.
Nice. Next question we got. Someone asked, this is a good one. They asked, how can you dedicate your career to something that's such a touchy subject in our world that we live in?
You know what? That I will tell you that everybody asks me, why do you do geriatrics? Isn't it very sad? Isn't it? I think it is the most fulfilling field that I've had. Like I said, I was a surgeon back home. I have done surgery. Um, and it's very funny that Atul Gawande also actually is a surgeon and has gone into palliative, and he talks a lot about death and dying, and he's written books about it. So I don't know. Maybe it is when you're a surgeon and you think you have a control over everything, and as you practice and practice medicine, you realize how little control you really have. Um, so I think the 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 beauty is that I feel like I can help my patients and their families navigate the complex medical system that we have and really make it easier for them as they're navigating the end of life. I think that gives me a lot of pleasure.
Nice. This is a really good question we got. Someone asked, how does how does hospice care adapt to the unique preferences and cultural backgrounds of specific individuals?
Okay. Very good question. And I will tell you that they do. So, obviously they have a chaplain, but they will reach out to your priest from your temple if need be. And they are very, very open to, being inclusive, inviting them, learning about your, whatever your cultures and beliefs are. Certain cultures, they, want the body bathed right after, some they don't. Some people will, women cannot touch some. So there are different things, and they really imbibe them and incorporate them. But they will reach out to your clergy and they will learn about those things. I mean, no one knows everything, but they make the effort to learn and incorporate them.
Nice. Someone asked, so they understand correctly that our guest speaker is a physician specializing in geriatric care. And then the second part was, what age group and conditions of her area of what age group and conditions are her area of expertise, and which office do you practice out of?
Okay, so I do geriatrics. My office is in Englewood, New Jersey. So I deal with everything that is for every patient above 65. But I think dementia is my expertise. That's what I practice a lot of. And dementia and behavior is another part of what I deal with. And, if you're doing dementia, we all know it is a chronic serious illness. And up until now, we don't have a cure for it. So palliative care goes hand in hand with that. So that's, but I deal with everything from COPD, CHF, uh, you know, all the chronic illnesses like diabetes, hypertension, every one of them.
Nice. Next question. This actually came from someone who's a resident watching the live now. They asked, how do healthcare professionals determine if a patient is eligible for hospice care, and what factors are considered into going into it?
Wonderful question. So, hospice, like I said, is a Medicare benefit, right? And then you have eligibility criteria. Every diagnosis that you have, there's an end stage COPD or end stage renal disease, end stage cardiac. You have eligibility criteria that are defined by CMS. And what you can do is you can go on the website. There are all the criteria laid out, and that person, if they meet the criteria, they are eligible for hospice. The biggest criteria is that their prognosis is less than 6 months. Because this is a resident, I will urge them to Google e-prognosis. UCSF is a great institution, has developed an e-prognosis tool, and you plug in those things and the patient criteria, it will come up with what is the prognosis for this patient. And if the prognosis is less than 6 months, patient is usually eligible for hospice.
Nice. Here's a good one. Someone asked, sorry, 1 second, I lost it. Can you share some common misconceptions about palliative and hospice care that people often do have?
Yeah, I think the biggest misconception is that once you go on hospice, the hospice wants to give you a morphine and kill you. I think that is the biggest myth that is hanging around. We have had patients that have come off of hospice, right? So there are certain diseases like dementia where it's a peak and valley. And you can have a peak when the patient has had no infection and is doing very well, but they'll go through a valley where they've had a recent infection, a sepsis, and they're not eating, they are getting dehydrated, they've got a bed sore, and they've gone through that valley. Uh, with supportive care, a lot of times they will recover because they're getting the attention, and they'll start gaining weight back again, and they'll come off of hospice. So it does not mean that, and CMS does not hold you. You said the patient is going to live for 6 months, and now the patient's living for 8 months. How come? That is not what the CMS is coming to say. CMS says that in your clinical judgment, if the patient's disease has a natural trajectory, that this patient's likelihood of passing is high in the next 6 months. That's what they're saying. But sometimes with supportive care, because really, the saying goes, care really starts when hospice starts, because now you have such a huge team taking care of this patient. And then when there is so much attention given to a particular patient, they do get better sometimes. So the the other misconception is that morphine kills patients. And I think there are residents watching this. We used to use morphine for treatment of flash pulmonary edema. We all know that, right? So, morphine does not kill patients. Yes, if used in a wrong way, fentanyl kills patients, ketamine kills patients. We are hearing it every day in the news. Um, the reason we use morphine is because it's easily administered. It can be administered sublingually. It's quick onset of action. It's natural. It has very less side effects. Like, you don't get a lot of other side effects like confusion, hallucinations, and all of those things. So we want to use something that is easily administered. Patient is not able to swallow, but seems like groaning and moaning and in pain. You can just put it at the side of their tongue. It gets absorbed sublingually, and that's why. And it's got a quick onset of action. But we're not giving morphine to kill patients.
Nice. Someone just asked this. They said, I know you mentioned dementia. Can you discuss any of the advancements in dementia research and any potential breakthroughs?
Yes, we actually have two medications that we are using now for mild cognitive impairment and early cases. They have been approved by the FDA. They still have not been approved by the CMS because they do have their own side effects. They come with their own baggage. Um, First of all, they're very, very expensive. There have been issues with, bleeding inside the brain. And I'm talking this layman term because I don't know who all the audience is. Um, And so the skepticism around the cost and the side effects of the drugs, that is the biggest issue that is holding us back. But we are hoping that we are going to see real breakthroughs. I think just like diabetes, which has several modes of treatment, dementia is going to need several modes of treatment. It's not going to be one treatment cures it all. So
Yeah, and dementia is pretty scary
yes,
because when I have families, and again, obviously I don't treat dementia, right? Because I deal with the young folks, but if I always see grandparents, right?
yes,
Then again, the parents share with the pediatrician more than they share with their doctor sometimes.
of course, of
Because
course.
they trust you in a
Think
unique
they're
way.
pediatricians more than anyone.
Yeah. And so you're like the pediatrician by day and the family therapist by night. And
Yes,
dementia is like, I think, something that we're going to hear a lot more about because you could give me your perspective. I'd be curious, but we're getting better at preventing and treating diabetes, preventing and treating cardiovascular disease, preventing and treating MIs or whatever. We don't know exactly what causes dementia, and we're very far from preventing it. And the older the society's living, the more dementia there is, especially as we're chipping away at other old school causes of death. And we're certainly not great at treating it, right? There's no, you can't do a balloon cath, when I was a kid, when I was a kid, if your uncle had a heart attack, there was like a 50-50 chance he was going to die. Now, when someone in your family gets a heart attack, you're shocked if they die,
yeah,
right? But dementia now, because of our improvement on those other morbidities and really our lack of awareness and stuff, dementia is getting to be more common. And then the other thing I'll say, unlike those other diseases, dementia is a direct attack on the family, meaning when your grandma has diabetes, as she's suffering, she still knows who you are. She doesn't forget who you are, and she can still be your grandma. Dementia often has just as profound an impact on the family because imagine your mother that you've known your whole life. Every other day you're with her now, she really doesn't know who you are. Imagine looking in your mother's eyes and she's like, "Why did you come into my house? I'm going to call the police." There's different versions of that, but dementia really affects the loved ones in a way these other diseases don't necessarily. And so I think this is a topic that, whether it's breakthroughs or whatever, it's a topic that we're going to hear more about, and it's happening to a lot of families now who didn't know much about it.
yes, absolutely. But I think there is lifestyle modifications you can do to prevent early onset, like, physical activity, good nutrition, good
Always.
sleep. Sleep is extremely crucial, that we all don't, uh, you know, especially the younger generation, is always having a
Guilty.
hard time not wanting to sleep. Um, and then, learning something new. I think learning something new is all that we forget, being social. So these five things I would say are extremely crucial. Good sleep, good nutrition, physical activity, learning something new, whether it's learning a new language, learning a new instrument, learning, and staying social. Very important.
It's almost crazy that every guest we have on, nutrition and physical activity gets brought up.
Yeah.
But anyway, and sleep. But anyways, next question came from this mom. She asked, "I'm an inexperienced first-time parent. Just curious, if a child has a life-threatening disease and is not expected to live that long, do they apply for hospice? Just curious."
Absolutely. And I think I would urge you to talk to your primary team. And, palliative care for pediatric population also exists. I would really enlist them, and involve them. And then eventually, yes, you should consider hospice.
Nice. Next question. Kind of actually went over the question is, I'll ask it anyways. What's one piece of good advice you can generally give to any families that come to you for hospice?
For hospice?
Yeah.
Um, if they're coming to me asking for hospice, I think the education that I would give them is, go over their eligibility criteria depending on the disease, that the patient has, and then, explaining what the benefit is, and how to maximize the benefit, and then, let the hospice come in, evaluate the patient, and then, enroll them. But I think one piece of advice for everyone that is watching, get your 5 wishes done.
The 5 wishes, nice. Gonna do that tonight. Next question. Someone asked, this is actually a good one. How do hospice professionals address the spiritual needs of a patient during their journey that they're going down?
So again, very good question. They have a chaplain team, and the chaplain team can enlist anyone that is, from your local temple to a temple, anywhere in like whatever state you're living in. So they will, they sit down with the patient and their family, go over their spiritual needs. They go over what you would like to have, what you would not like to have, and what your preferences are, what your preferences are not to have. And then they can enlist anyone that you would want them to bring in to be able to serve you.
Nice. Here's a more positive question. Someone asked, can you share some examples of meaningful moments or stories that highlight the impact that has had on your hospice career?
Several. Um, so, being that I was a hospice professional, uh, two of my very dear people, one, my father in law, was very, very dear to me, um, lived with me. And, he was one person who was 94, turning 94 the day he died, um, would still wake up in the morning, make bed tea for myself and my husband because he didn't like anyone else's tea, and he would bring it from the kitchen to our bedroom. Uh, he got sick a day before his birthday. And what happened to him, he got up, he fell down. I checked on him. It was January, more likely a flu. Um, he had a temp of 103. And I said to him, let's go to the hospital. I think you have flu and maybe sepsis. He had had colon cancer in the past. He'd had prostate cancer. Everything was cured. He was writing a book actually at that time. He had just finished writing a book. And his daughter was visiting from Arizona, his oldest daughter. And he goes to me, how many months are you going to give me to live? And I said, what do you mean? You're very healthy. You are, he'd made bed tea for all of us in the morning.
Yeah.
And he said, you're going to give me 6 months, a year? He says, I feel so weak right now that I wouldn't want to live like this. I'm so happy that, all his grandchildren were, obviously they lived at home. Um, and he says, let me go. It would not have been easy for me if I was not a hospice professional to do that. I actually still was agonizing, even though I was a hospice professional, because he really had a good quality of life.
Yeah.
And so I called my oldest sister-in-law and I said, he's just not willing to listen. And I said, can you just go and talk to him? I told my husband, I said, go and talk to him. Maybe he'll agree to going to the hospital. And he says, I've already told Ritu what I want. I don't want to go to the hospital. And he stayed at home. All the grandchildren came. They played cards with him all all throughout the evening. They were all sitting by his bedside. They played cards. They, played games with him, board games. By the evening, he was blue in his lips and his fingers were blue. Uh, he eventually passed away very comfortably in his own bed, surrounded by his grandchildren and his entire family. The second episode was my own mom, who also came to live with me. She also had very severe rheumatoid arthritis, severely osteoporotic. She'd broken both her hips in the past. And, she had rheumatoid lung and rheumatoid heart. Um, so she had started walking, and she was a mountain biker and a hiker in the past. And so she fell in my bathroom and she crushed her pelvis. And so she thought, you know, initially we thought that, this will heal. But after 6 to 8 months, she realized she's not going to walk. And she said, this is it. I'm not doing it. I can't live. I don't want to live if I can't walk again. Um, Again, it was very hard for me to have convinced my. It would have been much harder for me to convince my dad and my sisters, that that's what she wants, um, and she just stopped eating. And my father would force her, have you love tea? I'm gonna, and he would feed her tea, and my sister would like, take something. This is what you like, and she would keep saying, I don't want it, I don't want it. And she passed again at home, surrounded by her grandchildren and all her children in her bed around her with prayers. And so I don't think I could have done either of those two if I was not a hospice professional.
That's really, yeah, go ahead. It's like a two-part question, I guess.
Sure.
Is New Jersey an assisted suicide state for hospice?
So it's not an assisted suicide state, but we do the medical aid in dying is approved.
What are your views on assisted suicide?
So I don't believe in assisted suicide, but medical aid in dying when your patient has full competency and they are consistent about their wishes. I've actually had 4 patients who've done the medical aid in dying. Um, 2 of them had ALS. One had advanced Parkinson's, and the third person had advanced cancer. Fourth person, I'm sorry, and they have benefited from that in terms of, they were very clear and consistent about their wishes that they did not want to live with this serious illness. So that is one prerequisite that you have for medical aid in dying, that you have to have a serious illness that you, again, then the second thing is that there has to be consistency in your request. Um, and you have to have capacity to make that decision. Um, and then you have to be able to take the medications on your own. It cannot be administered to you. So it's not like as if your daughter or your son or your wife can administer the medications for you. You have to be able to take it on your own. So if all the criteria are met, it's a great thing.
And how would how would someone judge if that person's at capacity to do that?
Oh, so we have a full capacity evaluation, and that's a
Okay.
chapter in itself. I can talk about it. I do capacity evaluation, so as a geriatrician, we need a lot of that. But that's a topic in itself.
Yeah. Next question, back to DNR. Someone asked, how does hospice ensure that their patients' wishes regarding resuscitation align with their values and preferences?
Oh, that is again, it's a good question because DNR is something that a patient is requesting that they do not want to be resuscitated if their heart stops and they want to allow natural death. Now, again, you want to make sure that the person has capacity to make that decision. They understand the consequences of not being resuscitated, and they also understand the consequences of being resuscitated and what their life is going to look like after. So, um, so once you've determined that the person has capacity, you explain them what a resuscitation is, what their risks and benefits are. If they do understand, then there is a form we call the out of hospital DNR form that we sign. It's on their refrigerator when the EMT arrives. They see that that form is stating do not resuscitate, then the EMT will not resuscitate. And now, actually, we have a form called the physician's order for life sustaining treatment, which is called the POLST form. In New Jersey, it's a green form, and it says very clearly, what your wishes are. Do you want to be resuscitated, or do you want to allow natural death? Do you want to be intubated, or you want to allow natural death? And so those preferences are listed on that as well.
Nice. For Z, what happens? Someone asked, what happens if a child is sick with a serious disease, and how does your relationship with someone like Dr. Siri help with that kid situation?
I think, like was mentioned, like the Children's Hospital has pediatric palliative care. And while it's much less common in kids, we have kids with terminal illnesses. And as sad as it is to see grandma suffer unnecessarily, it's way sadder to see an 8-year-old. And also, the 8-year-old really was never in a position to make an informed decision. So the confounding variables are even heightened, and the emotions are even heightened. Like as bad and complicated as it might be, when someone who's 80, 90, has lived a full life, there's something to be said for that. When an 8 year old, the emotion, when a parent, I used to have to, I worked on the pediatric oncology service. And the one thing that never happened was a rational discussion with the families, right? And these are very educated people who only care about their kids, but you can't see straight or clearly when, your 8 year old or 9 year old, you're being told that there's no hope, for lack of a better term. And so that's a very unaccepting position for most parents. So um, expertise like we're hearing about tonight is even more important at that time. And the conversation, I've been part of many of those conversations. Those conversations are very delicate, right? When you talk to the family about it. And I had kids who had like 2 or 3 bone marrow transplants, which suck, which are painful and really bad. And when I throw out a term like 2 or 3 bone marrow transplants, what's left out is if that takes place over a year, each one there was a spike in anticipation of cure, and then we do the blood test, and oh no, and like the emotions, and then you're trying to, I don't want to say hide those emotions from the kid, but imagine managing expectations in a kid who doesn't really understand what's going on. It's pretty complicated, and all that is to say this expertise is even more important in those situations.
Nice. And then someone else also asked for you. I know you probably don't touch on the subject as much, but have families ever come to you for your professional advice on like their kids and going through this? And
Yeah,
like, what was your advice to the parents?
yeah. Like I have kids that I take care of that end up in the hands of specialists, namely oncologists. Um, I've had a couple of kids that had severe motor vehicle accidents and they never got out of the hospital. So I was pulled in because they were in the ICU, and devastating permanent brain damage and coma and so on. And they'd get transferred. Both of these kids were transferred to Columbia from Jersey, and I've actually had a handful that were preemies, so they're like a week or two old. They're on ECMO or ventilators and so on. Um, and then they're in the NICU, for like months. And yeah, they'll come to me, although they're generally not under my direct care. They're under the care of a specialist or the hospital, but they come to you for advice. But usually by then they've established pretty strong relationships with the care team in the hospital too. But they come to you, like if I'm taking care of their older kid for 10 years, they'll come and they'll say, Z, what would you do? What this? And you give them your honest opinion. And and I always tell them, in this case, when your kid has pneumonia or has meningitis, with all due respect, I'm giving you more than an opinion. I'm giving you an expert opinion. Okay. When it comes to this stuff, I tell them it's an opinion, right? And your intuition as family, like that should trump my expertise, because this is an area you tread out. The level of expertise goes down, right? I think with experience comes expertise, right? So what you're hearing from my colleague is a lot of experience. And so the experience can be directed towards like, okay, dementia, here's things we do know that can help mitigate it. Um, if you want to do what's right by somebody, even though somebody's view on death can be different, here are the mechanisms you could take so that you know what their view is before you're speculating and guessing, to control what could have been chaos. And that's an emotionally charged situation. With kids, again, nobody prepares for that. There is no foresight toward that. You're right. It's never easy and you're never prepared.
Do you feel like, are you guys like kind of, I know doctor, you're like trained for like death in a sense, because
Mm-hmm.
because he like, have you like kind of prepped for it with your key patients? Because I know you like, even before like the child is born, you're building a relationship with the parent and all of that, and then like God forbid the parent has complications with the birth of the child. How have you like prepped yourself for those things, or you just like blindsided like?
Yeah, I mean, I haven't, one thing as a doc, as most doctors, I think, and you could speak to this, you've seen so much that the word numb is not the right thing, because numb
And
connotates.
compassion
Yeah.
outweighs trumps everything. I think the compassion that comes out of a physician, like it is easy to say that I'm comfortable with death and dying. Every time a patient of mine dies, I think we lose a part of ourselves. Like it is not easy because you've built that relationship, and it is not easy to lose a patient. Like, I mean, I recently lost two 96-year-olds who were really full of life. Like they were like too full of life. They, you know, um, I had, you know, they were my patients over 17 years now. And so it's just, it is, I think it's compassion and really putting yourself in their shoes and, being there for them. You might not have all the answers. And it's as long as they can see that you're willing to help out and you're helping them, you even just hearing them out. I think half the time they feel that they're not heard. And, that causes a lot of distress. And I think as a primary team, I feel it's the same for pediatrician as a geriatrician or an internist who's in the primary care practice. I think we are very good listeners. We are compassionate. We love holding their hand, and I think just listening to them, I think that's what they need and seek more than anything else.
Nice. And then I think this is our last medical question. And this is a good one. Someone asked, in what ways does hospice care extend support beyond the patient, considering the well-being of the whole entire family?
Oh yeah, so
Good question.
Yeah, it is hospice. Actually, the benefit includes the support for the family. So the social worker, the chaplain is not just for the patient. In fact, a lot of times when the patient is in the bed, unable to answer questions, advanced dementia, unable to breathe, unable to talk, it's not about the patient. It's really about the people around, and the family or the friends, whoever is around taking care of the patient. And then hospice benefit includes actually 13 months of bereavement support after the patient passes away. So very good question, and I should have thought about it, answering that earlier on. But yes, they include that. Even after patient passes away, that benefit is still there for almost 13 months.
Awesome. I think that's all I have for medical questions. So let's get into some of our non-medical ones. And Dr. Suri, excuse us if we get a little too into the sports.
Into sports. Oh, I'm very bad with sports. I can bring my son here, but
um, Z, someone asked, what are your thoughts on the Eagles and Cowboys collapse?
ooh,
As a Giants fan and them being our
It was
rivals,
amazing.
loved it.
Yeah.
But we're like in such bad shape. I can't even, if we were close, them going down a step and us, if we were a step away, that would make a difference. Our conference is a mess.
Yeah.
We're the biggest mess in it. I mean, even the Redskins are looking up compared to us. It's a disaster.
Yeah. And then their second part to that question was thoughts of the playoffs so far and divisional round predictions.
Playoffs have been good. Can't bet against the Chiefs. Right? The Chiefs Bills game is going to be nuts.
Nuts.
Who do you have?
Who do you have?
I'll give me the Chiefs.
I think the Chiefs too. I don't think
And
Josh
the other
Allen-
conference,
And then you have the Ravens, and I don't even know who they play.
the
but
Ravens,
The Ravens. And no, that's the East.
Tampa Bay.
No, they don't play the Tampa.
No, I'm saying they're
Oh, yeah.
also in.
Green Bay. And then you have what? Green Bay and the Niners.
That's a great game. That could be that. Those might be the two best teams.
That game's gonna be really good.
Yeah,
And I think I'm leaning Green Bay.
yeah, yeah. That's a smart money.
I wonder if our biggest Cowboys fans in the live.
They're very quiet. They're very quiet right now.
And then Bucks Lions. I think the Bucks are gonna win too.
Wow, that's a good one.
Yeah, it's a good game, but I don't think.
Those are both overachieving teams.
I think the Lions are getting a little too cocky.
Gazy.
Yeah.
Yeah.
Um.
Can I circle back to like one thing?
Sure.
So I remember you talking about like you went to a celebration of life.
Yeah.
Have you
I crashed it. I wasn't invited. It's next door to yeah.
But have you ever seen like in New Orleans when they do like the funerals?
No.
It's literally like a marching band, and everybody's dressed in like the most colorful outfits.
But the person's dead.
For the person's dead, but it's a marching band. They're dancing down the streets. They're literally like doing this with the coffin and then walking to it.
Yeah.
It's their version of the celebration of life too.
Yeah.
It's like that's been the culture there. It's insane to see like how you were talking about like
Yeah.
how people are like, oh, don't play music, don't make jokes. But I feel like you want to celebrate that person. You want
Yeah.
to see the funny side of it.
Yeah, agreed.
Yeah. Someone wanted to know your thoughts on the Siakam trade.
Don't
Or
care.
yeah,
It's nothing. Knicks are on a tear though.
they are. I don't. That's all I have for tonight.
Well, I like usually I get like really into the sports stuff, but I don't think I've heard like as touching a story that you shared the personal story about your family. And like I always find, and I've said this before, that the people who do something professionally that's informed by their personal experience are the ones who do it the best, right? And I'll never get off that position. I always see it where there's a perpendicularity, where it kind of blurs. And I want to thank you for sharing such a personal journey. And
Thank you.
it's
Thank you
Very.
for
It
having
was
me.
amazing.
that was
Very
amazing,
touching.
right? Like that was very touching,
Thank you.
and informative. That was incredible. I look forward to having you back if you're
Thank
willing to
you.
be back. And I'm sure everybody learned a lot tonight.
Thank
And
you.
so
Yes.
hopefully everybody digests this kind of
The
heavy but
community
very
learned, yeah.
important conversation.
I hope it was not too heavy for everyone, but
It was actually very informative. A lot of them were very thankful for the chat we had tonight.
thank you.
Thank you again.
Thank you so much.
Appreciate it.